in the neuromonitoring, in the SSCP, what do? You measure, you give in the leg some electric signals. They pass through the posterior element, meaning the back of the spinal cord. They go all the way to the brain, and you measure the response. Every time you work in the spinal cord, or these pathways, especially the posterior element, if you remember, spinal cord look like a butterfly. You know, this is the cross section of the spinal cord, and then the cells, they look like a butterfly. Remember that part? This is the cells, this is the pathways, and the posterior, this is back of the posterior pathways, are those sensory, cuneatus and gracilis. You remember that? Do you know exact description of them? The gracilis is the legs, the cuneatus is the arm, and you can imagine them that, you know, those pathways that go from the leg, they are inside. The pathways, they go from the arm, they are outside. So practically, with SSCP, you are measuring the integrity of those levels, of the cuneatus and gracilis path tracts. Why is it important? Because most of the time we work from the back of the spine. By you measuring how much these are damaged, you can tell us, are we being too aggressive or not? Would that be an issue in the sacroiliac joint? Not really, because we are not putting any pressure posteriorly in the spine. Now, why do we even do neuromonitoring in the sacroiliac joint? Half of the people actually don't. I use it as a safety mechanism because the way I do the surgery, I go from the outside to inside. I go through the iliac crest, I go to the sacrum, and there are mostly 3 nerves that are at danger there. Just looking at that, can you tell me which nerves are mostly at danger for the sacroiliac joint when you go from the screw from here to here?
Right.
Obviously, S1,
S1 is 2.
rarely S2. I mean, you have to be way off, but yes, but mostly S1. Now, what else can be a danger? If you are coming up, you can stick out the screw out of this here. You see, which one is that one? L5. So S1 and L5 are the mostly what's really important. Now, in a real person, obviously L4 is not cut like that, right? L4 continues. What's the trend of the L4? It comes here, goes down here. So in certain situations, if you're really off, you can as well have a L4 and S2, but mostly L5 and S1. And all what we are looking for is, are we contacting them? Are we pushing on them? So for that reason, free EMG, meaning that you are just, what do you do in a free EMG?
Just monitors muscle activity.
Muscle activity. And if I'm hitting something, you will get a muscle activity, right?
Yeah.
So free EMG, and then we stimulate them, mostly stimulate the screw to see if they have contact to any of these nerves. So as you see here, because of what we just described, because we are not putting anything on the posterior element of the butterfly, those tracts, sensory tracts, that's what it measures, SSCP. That's not a crucial thing for sacroiliac joint fusion. Okay, now where would be the tracts for the motor tracts?
Be more anterior.
Where exactly? It would be 80% would be lateral here, 20% is front here. Okay, so that makes sense now why in the ACDF or when we do big corpectomy and so on, when we go from the front, that would be of importance. So do we need to do any, the motor for sacroiliac joint? Obviously, because of that as well, we don't have to, because we are not going to put any, hopefully, not from sacrum, going to come and put pressure in the posterior anterior element of the spinal cord.
Okay.
Now, regarding sensory and motor, generally, when you are really within the spinal cord, like when you're doing the tumor, motor is very important, or when you're doing a really major thing that is anterior, like corpectomy and so on. ACDF, a regular ACDF is give and take. You can or you cannot do. Most of people don't. It's an individual, but if somebody has myelopathy, that has a huge value. You know, can you describe what myelopathy is?
Not exactly.
Myelopathy, if the cells inside the first motor neuron are affected and damaged, when the first motor neuron are damaged, that's a clinical and radiographical picture, meaning the spinal cord is already damaged under pressure. Then you want to have all the information you need to see if you are causing additional pressure or damage. Okay, so for this sacroiliac, long answer to your question is, free EMG and stimulation is actually all what we need. Okay, except, you know, if you're concerned about that patient has some other condition that during the positioning something else might happen. Does that make sense?
Yeah.
Okay, thank you.
Yeah.
We're ready in the OR.